This is my MSICS technique. I don't do any conjunctival recession. I use a 2.4 millimeters phaco knife. Start my incision about 1 millimeter behind the limbus, going straight into the cornea, causing a very bevel incision. It's not a very deep tunnel, but it's about 3 or 4 millimeters into the cornea. I then enlarge my wound to the area behind the limbus, about 3 or 4 millimeters behind the limbus. This is a patient that's being done under topical anesthesia, so I introduce a little bit of intracameral anesthesia as well. As you can see, the nucleus is not very dense. Then I place viscoelastic in the anterior chamber, not to overfill the anterior chamber, just to maintain the anatomical structures in place. Since this is not a very dense nucleus, I then proceed to do a 6 millimeter capsulorhexis using the cystotome. In nuclei that are denser than this, I use the can opener technique, capsulotomy. I then do hydrodissection to make sure that this lens is loose, and I do it in both directions. Once that I loosen up the lens, then I proceed to rotate it and make sure that it's totally rotating into the capsular bag. I expose the equator of the nucleus, push it up a little bit, and then rotate it counterclockwise to force the nucleus to come out into the anterior chamber completely. I then do the extraction of the nucleus by using a lens loop. And I used a 20 gauge cannula to irrigate the big chunks of cortex that are left inside the anterior chamber, helping out the extraction of the cortex this way. I then use a 23 gauge Cinco cannula to do the irrigation aspiration of this cortex. And I tend to get rid of the easier pieces of cortex that are floating in the anterior chamber first. Then I proceed to do more cleaning by using the Simcoe cannula to grab the cortex and pull it into the area in the center of the pupil, where I can see it and aspirate it. I am very gentle at this point. I don't do a lot of almost any aspiration behind the iris because I cannot see the tip where I am exactly, so I'm very careful, but I'm careful to grab the cortex, bring it into the center of the pupil, and then aspirate the cortex, making sure that way that when I'm aspirating, I know where I am and I know where I'm aspirating. I leave the toughest parts for the end. I clean up the cortex in the capsule bag, and I leave the hours from 11 to 2 o'clock or 3 o'clock for the end. The 12 o'clock cortex is the most difficult to do, so I leave it for the end, hoping that by irrigating it would hydrate and be easier to grab and aspirate. As you can see, I'm always trying to grab it and pull it into the center of the pupil where I do the aspiration. I try to clean all the cortex out of the eye to avoid any further inflammation on this patient. Sometimes when I'm working at 12 o'clock and I can see that the cortex is not very easy to aspirate, I do a little rubbing on top of the iris to loosen up the cortex from the capsular bag, bring it out, and then I'm able to aspirate it and clean it up. I make sure that the capsular bag is clean as much as I can. Here we go, doing a little rubbing on top of the iris, loosening it up, aspirating it, cleaning it up. Then I proceed to put some viscoelastic in the pupillary area and inside the bag. Not overfilling the eye with the viscoelastic, just enough to make space for my intraocular lens implantation. I then proceed to put a C-loop 3-piece lens into the capsular bag. I then clean up the viscoelastic that remains in the interior capsule, and I don't do a lot of going under the intraocular lens to avoid any further complications. I push it up a little bit, push the viscoelastic into the interior chamber, and then aspirate the viscoelastic. After I aspirate the viscoelastic, I use an old technique that I've used for so many years by sealing my wound with an air bubble. In this way, I don't have to do any suturing.